Hello everyone. Hope you are having a fantastic conference. Michaelin has asked me to give this short presentation on radiology in everyday practice. Its focus will be on practical imaging decisions for frontline healthcare professionals. I do not have any commercial declaration. I am affiliated with more than a dozen medical and radiological societies. I am chairman for British Institute of Radiology, Southwest, and Global Education Faculty for the Royal College of Radiologists. I've been head of radiology at University of Bristol where I teach medical students. I teach radiographers and nurses at University of West of England. I work at North Bristol NHS Trust, which is one of the largest in the UK for teaching and training, and it is also a regional trauma unit. I've been specialist advisor to BSc Charity run by Michaeline and her colleagues who are doing a fantastic job. My other interest is writing medical textbooks, which have been well received by readers and won a number of awards. This is my current hospital, which has 5 MRI scanners, 5 CT scanners, and on site PET CT. I worked in USA, but my initial training was in Delhi, which has fairly similar challenges to Caribbean practice. Wherever we work, I've realized that there are some common themes. One is timely reporting, especially after hours or at the weekends. There are cost constraints, transport limitations. For example, in USA and Australia, nearest hospital may be 300 miles away. There are radiation concerns, particularly in children and during pregnancy. And there is limited availability of MRI and PET scanners, especially in district hospitals. UK alone is 3,000 radiologists short, but demand for imaging has been increasing, and as a result, more than 300,000 patients waited more than a month for results of their X-ray. Key takeaway messages would be on modality advantages and limitations, their relative radiation risks, apply imaging to real clinical scenarios, and select right test first time, and recognize critical and emergency findings. There are 4 pillars of radiology. Diagnostics has been the oldest, where we look at X-rays or scans to come to a radiological diagnosis. Interventional radiology has come a long way in the last 30 years. Radiologists are also gatekeepers for patient safety, especially if any tubes have been inserted or any devices such as pacemakers, which may lead to pneumothorax. Increasingly, radiology is being used in preventive medicine. Looking at each individual modality, X-rays are fast, cheap, and widely available. You can do bedside X-ray on the ward or in ICU, but they offer limited soft tissue detail and they are not exactly 3D in nature. Ultrasound does not carry any ionizing radiation and can be used bedside, and it is relatively cheap compared to CT and MRI, but it is operator dependent and there are some deep structures. If there is presence of bowel gas, then we can't reach structures like pancreas or retroperitoneal lymph nodes. Fortunately, CT can access all those areas and offers excellent 3D anatomical detail. It is fast compared to MRI and therefore modality of choice for trauma patients, but it carries high radiation dose and you have to give IV contrast in many body parts, which can be tricky if patient has poor renal functions or have previous contrast allergy. MRI offers excellent soft tissue detail and does not carry ionizing radiation, but it is costly and slow. Some imaging protocols can last for up to 45 minutes, so may not be suitable for young patients, especially children, and not suitable in emergency setting. And MRI has relatively limited access compared to CT. PET scan uses radio tracers such as FDG to map metabolic activity, especially in cancer imaging, cardiology, neurology, and to pick up infections or inflammation. But because it is costly, it is mainly used for cancer staging, for staging of lymphoma, lung and colorectal cancer, in melanoma, and it is excellent tool for picking up treatment response or any recurrence of tumor. Its main limitation remains high cost and high radiation dose. We must work on the principle of ALARA, which is using as low as reasonably achievable radiation, especially if we are dealing with children or young adults or during pregnancy. Also think of modality which does not involve radiation if patient has to undergo repeat imaging. For example, a child with epilepsy, MRI would be better than a CT scan. So if we assign 1 unit to a standard chest X-ray, then abdominal X-ray will be equivalent to 35 uh, chest X-rays, and CT abdomen would be approximately 250 depending on your type of your machine. Fortunately, ultrasound and MRI do not carry radiation burden. Looking at diagnostic framework, it is important to be specific in your clinical uh, history because vague questions may get unhelpful imaging. Is imaging urgently needed or could treatment start without it? For example, in the middle of night when MRI may not be available and patient is suspected of raised intracranial pressure or spinal cord compression, then you might like to start steroid therapy and get imaging done at next available opportunity. Will results change my management? If patient is do not resuscitate, then doing fancy imaging may be waste of resources. Chest X-rays, bread and butter of most radiology departments, is often done for infection screening including TB, if there is family history of cancer or if you are suspecting metastasis or heart failure. It is part of trauma screening as well. One should follow ABCD system to look at airways including trachea, main bronchi, look at the lung fields, exclude pneumothorax, consolidation or pleural effusion, look at heart size and look at diaphragm to exclude possibility of diaphragmatic rupture, and then look at everything else including bones, soft tissues, lines, tubes or any devices and foreign bodies. X-rays are useful for trauma, but when dealing with facial or skull fractures, there is lot of overlap of bones. CT offers 3D imaging. It shows bones without any overlap and shows soft tissues in excellent detail. But then it has its limitations. In this case of trauma, it shows forward shift of C2 vertebra here, but we can't tell whether cord is compressed or not. When we did MRI, a shift of vertebra is seen and cord is compressed at this level. And on these are T2 images which shows cord edema. That means it is compromised. In this case, Clinicians strongly suspected lymphoma, but spleen was normal in size. There was no focal lesions, but patient had night sweats, loss of weight, and LDH was positive. So based on strong clinical suspicion of lymphoma, we proceeded with PET scan, which showed diffuse involvement of spleen. So remember, lymphoma can occur in normal size spleen or lymph nodes, and PET is better than CT. Looking at acute abdomen triage for right upper quadrant pain, you can do ultrasound as first line. It picks up gallstones, cholecystitis, liver abscess, or pancreatitis. For renal colic, ultrasound can pick up hydronephrosis but may not pick up small ureteric stones in some cases. Then you have to proceed to CTKUB. If appendicitis is suspected, ultrasound is first line in children and during pregnancy. If radiation is not a concern, you can proceed to CT scan. For bowel obstruction, CT defines the level of obstruction and more specific. But if it is not available, for example, while working in remote town, then one can always use abdominal X-ray. For trauma, a CT scan is gold standard, but again, if availability is limited, please perform a chest X-ray, pelvic X-ray, and any other long bones or even cervical spine if cervical injury is suspected. And you can do fast ultrasound, which picks up fluid in the pericardium, in the peritoneum, and it can exclude rupture of liver, spleen, and kidneys. Coming at the second pillar, interventional radiology, we can do vascular interventions including angioplasty, stenting, embolization of hemorrhage during trauma, intracranial hemorrhage, GI bleed, or postpartum hemorrhage. We can put stents for biliary drainage, nephrostomies for obstructed kidneys, ascitic or pleural tapping, or drainage of abscesses. We can perform CT and ultrasound guided biopsy to obtain tissue diagnosis. And increasingly, we are doing tumor ablation, and we'll see some examples later. So this is an intracranial aneurysm, and as a radiologist, we can put steel uh, coils, or we can embolize these aneurysms. We can do angioplasty or put stents for blocked arteries. For vertebral fractures, we can perform vertebroplasty if it is just osteoporotic fracture, but if uh, fracture is due to malignancies such as multiple myeloma, we can perform a triple combined procedure where after putting a needle, we can obtain tissue diagnosis. Then using radio frequency, we can burn the tumor cells and later put cement to strengthen the affected bone. In certain cancers, such as renal cancer, which are not sensitive to radiofrequency ablation, we can do cryoablation where we can freeze dry them. We are also gatekeeper for patient safety. An ideal feeding tube should go along midline from esophagus into stomach, and it should be below the left hemidiaphragm. So NG tube is well sited, but you could see the left hemistherex is wide compared to the right one, and this is right heart border. Heart is shifted to the left, and the culprit is this um, endotracheal tube. Normally, it should stop at this level, but in this case, this has gone to right main bronchus, obliterating the lumen of the left main bronchus. So we should inform clinician that this tube should be pulled and placed above the level of carina. These are two different cases. Nasogastric tube should ideally go along the midline into the stomach, area, but in both cases it has gone into right main bronchus. So we should inform ICU nurse or ward nurse that patient should not be fed and this should be removed and replaced. There are other uses of imaging, for example, planning complex surgeries. We can send high resolution images to theater and surgeons can plan complex surgeries using VR technique. We can also do 3D printed models. We have been doing for past 20 years at our hospital. This child was born with deformity of mandible. 3D printed model was made which helped making a custom built prosthesis. Since then, we have done it for other deformities, for example, chest wall deformities, patient with pectus excavatum. We presented our findings in 2007 in America. Coming to the fourth pillar, preventive medicine and health screening. 61-year-old female presented for routine screening mammogram and we picked up this lobulated spiculated cancer. Imaging saves lives and these cancers can be picked before they become clinically palpable. Similarly, we are picking up polyps and cancers in rectum and colon and lung nodules, a lung cancer and using AI multiple nodules have been picked up. It can also give us tumor doubling time and at my hospital, for every single CT, we aim to now report presence or absence of coronary artery calcification so that preventive measures can be taken before patient develops heart attack or symptoms of angina. So whatever fancy techniques we use for diagnosis or screening, we can use same for medical teaching. First year medical students at University of Bristol do cadaveric dissection and they also learn 3D um, anatomy by MRI. And as head of radiology, I also introduced abdominal ultrasound for year 2 students because lot of biopsies or ascitic drainage can be done on the ward. Similarly, pleural effusions can be tapped on the ward using ultrasound. So key take home messages are ask a specific clinical question before any scan. Start simple with X-ray or ultrasound before CT. If ultrasound or X-ray can't provide, then we can always move to fancier imaging. Communicate clearly. A good referral gets a better report. Always correlate imaging findings with clinical picture. Imaging supports clinical judgment, but it can never replaces it. Thank you for listening. Sorry, I couldn't be there in person, but if you have any questions, please drop me an email. If you want to organize a conference in association with the British Institute of Radiology on any of the topics you have seen on the slides, please email me. Email me any questions or queries at gandhis@doctors.org.uk and you can always message me via LinkedIn. Enjoy rest of your conference and hope to see you in person next year. Bye.